an important question is certainly, how do we make choices about treatment? What kind of treatment do you start with? What treatment do you select for patients who have relapsed refractory CLL? And what are potential strategies to sequence therapies? And now that we have a number of choices in the targeted era of CLL therapy, this is really becoming an important question, and sometimes also a cause of anguish for patients of, well, do I make the right choice? Do I start with the best treatment for me? My typical answer to that is, well, this dilemma of making the right choice actually means you have choices, and it means you can adjust the treatment plan if it's not working out the way it was conceived at the beginning. We don't have a lot of data for all the possible combinations, but what we know, because BTK inhibitors have been basically the leading edge of this targeted therapy revolution, is that when patients progress on BTK inhibitors, often with mutations that affect the binding of the covalent inhibitors to BTK, there are now options. One commonly used option is to switch to Venetoclax at the time of progression on a BTK inhibitor. And that is an efficacious strategy. It depends a little bit maybe on the context in which this switch is made, but typically all the patients, or the vast majority of patients, responds to the switch to Venetoclax. There are studies that suggest that with time, there is a higher chance of developing also progression to Venetoclax when it is used after failure of BTK inhibitor therapy compared to when it's used as the first targeted agent. So maybe this would eventually also be a setting where we would want to explore combination therapies. The other important option that becomes available now in clinical trials for patients who progress on BTK inhibitors would be to investigate the use of a non-covalent inhibitor. And we've seen exciting data presented also here at iwCLL of pirtobrutinib, which is a compound that non-covalently can inhibit BTK, even if there is this cysteine 481 mutation. So that reasonably is another sequence, switching from a covalent BTK inhibitor right now in clinical trials to a non-covalent BTK inhibitor. And other options, maybe especially when patients have gone through both BTK and Venetoclax, there are still PI3K delta inhibitors that could be used in that setting, possibly with less response duration, but potentially as a bridging therapy to either CAR T cells or potentially in that setting, even still allogeneic stem cell transplantation. The other sequence is increasingly, of course, Venetoclax can be used as frontline therapy, is approved and shown to be very efficacious as a frontline therapy, time limited. So when these patients progress, depending on how soon after stopping drug, it may be reasonable to just start Venetoclax, and there's good data that the response rates to that approach are high. There's also good data now that switching to a BTK or instituting therapy with a BTK inhibitor after progression of first-line Venetoclax is also a reasonable strategy. So I think really many options that, and again, we'd really like to highlight the reassuring part here is that because we have these options, it should be possible in most settings to actually come up with a good plan for patients who need treatment.